we'll start this session with a very important and upcoming topic, which is the overview of myopia by Dr. Damaris Magdalene. She is from Shankardev Netralaya at Guwahati, doing an excellent work there, and it will be a pleasure to listen to Dr. Damaris, please.
A very good evening. I will be talking to you about myopia. Is it working? As we all know, myopia is a type of refractive error of the eye in which parallel rays from infinity will focus in front of the retina after passing through the refractive components of the eye. By classification, by appearance, you can classify it as simple, degenerative, nocturnal, pseudo, and by magnitude, whether it is low, moderate, or high. By age of onset, it could be congenital, young, or adult. By 2050, we know that the global prevalence of myopia prediction will be about 50%. But why myopia progression is a concern? Because research suggests that the odds ratio of ocular disease leading to potential blindness is increased by 2 times with low refractive error as low as -2 diopters. Actually, how does a person develop a refractive error? It is because of the genetically programmed ocular growth, which is the same in both eyes, which ceases by 14 to 16 years, and the visually driven ocular growth, which could be a blur or an interaction between accommodation and convergence. When there is a mismatch between this genetically programmed ocular growth and visually directed growth, person develops a refractive error. And this growth of ocular components requires a correlated growth between all these components by the axial length, corneal power, crystalline lens power, and the anterior chamber depth. We know axial length should increase to 24 millimeter, corneal power should reduce from 50 to 43, and the lens should flatten from 45 to 20 diopters by 6 years of age. This visually driven growth, it could be because of a blur, and it is said that it is a peripheral retinal image defocus which causes an increase in axial length and hence a myopia. And also in myopics we see a lag of accommodation, that is the patient accepts a more plus, and also because of transient changes in axial length following short periods of accommodation because of mechanical tension. Other potential factors include genetic, optical related factors, environmental factors. CREAM study, which is the largest genome-wide meta-analysis, based on 32 studies, have found that there are up to 24 genomic variations in myopia, and when there are 2 myopic parents, the risk increases to 12%. And again, SAVE study, SMS study revealed that near work was a risk factor for myopia. And the odds of myopia increase 2% for every 1 diopter of near work, and also when the child keeps the book less than 20 centimeter reading distance, the myopia increase. Researchers have found that it is not the sports but the exposure to the outdoors that appears to be protective, and they found that it is the spectral composition rather than the intensity. They found that outdoors releases dopamine, which is known to inhibit the eye growth. Children with 7 hours or less of sleep, they have a higher risk compared to those who slept 9 hours. This is a study conducted in China. And also LED lamps for homework after school had a higher prevalence of myopia, about 11.2%. This was again a study conducted in China. And again, when a child consumes refined carbohydrates, they found that it could be associated with childhood myopia. So this was again a study which was published in August 2020. So what are the options? So you do a thorough baseline investigations for near esophagia, accommodative lag, cycloplegic refraction, and the axial length measurement. See, when we do a biometry, there is this axial length to corneal ratio. When it is more than 3, there is a risk of development of myopia. It is a predictive factor. You can always inform your patients, oh, there is a tendency for increase in myopia. And again, when the myopia increases, when there is more than 1 diopter per year, it needs more aggressive treatment. So this brings us to the sequential management protocol, which includes your refractive error correction, maximum plus for myopia, and pharmacological like atropine drops, added lens, vision therapy, and diet modification. We have the spectacles. It could be either a single vision lenses, your PALs, your executive bifocals, and the defocus incorporated multiple segments. American Academy has given us a guideline for how to prescribe glasses in children. So normally when we prescribe the single vision lenses, it acts on the fovea, but actually we have to address the peripheral hyperopic defocus, which is what is the DIMS lenses. So it has an area of 9.4 millimeter with the actual power, and then the 33 millimeter which has islands of both plus and minus, which works on the peripheral hyperopic defocus. Orthokeratology, which is a non-surgical topographical approach, a planned corneal reshaping. When you combine ortho-K lenses with low-dose atropine, they say there is an improvement. This is what was published in July 2020. We have a bifocals and a multifocal contact lenses which serve to correct the accommodative lag. They impose sustained myopic defocus, which is considered to be inhibitory for eye growth. And of course, our atropine drops, which people are using left and right 0.01% at bedtime. And the vision therapy, basically this is basically used to reduce convergence insufficiency, indirectly maybe helping in prevention of progression of myopia. So ultimately, whatever it is, we have to send the message to the people concerned that children should learn to go outdoor and play, give them standard recommendations for screen timing. Maybe our future classrooms should be so that light rays enter the classrooms. General awareness to the parents, public, to the patient will definitely go a long way in treating the myopia. So it is a cooperative effort of parents, caregivers, teachers, social workers, public health professionals, and policy makers. Thank you.
Thank you, Dr. Saab. This was very nice presentation. What do you think about prevention of myopia with atropine 0.01% or 0.0 other any 0.05%? Which one is effective, and what age group ideally it works?
Usually, we usually give 0.01%, which is available in the market. We give it at bedtime for 2 years, then I give a gap of 1 year. And again, if the patients are still having, then again I start it. So maybe we can I start by 6 years up to 12 years, so that I have till 16 years, 5 years we can work on the patient. If they are not improving, I've added now dim spectacles. I think I've given about 80 children with dim spectacles. Till now, maybe one patient has reported to us, maybe to the optical shop, saying that they are seeing a glare when they look at when they move the eyes. So I've instructed them to keep the eyes focused straight. No, only when they move their eyes, the focus will fall on the defocus elements. So we are the patients have not yet come back. 1 month review is not, 1 year review is not there for the dim spectacles.
Actually, the follow-up is long term.
Yes.
Because we don't know in the short term period what is the effect of this drug. So this is over a period of several years.
Yes.
That how it progresses.
I think I have submitted, we have submitted some patients to for the LAMP study.
Yeah, we hope to. We have collected data from all over the country. We have now 2-year follow-up data. Hopefully we should come out with the results in this very month. We are in process of analyzing it. We have now over 600 patients with over 2 years of follow-up. So we hopefully would come out, so we'll know better how the drug acts in the long term in our children. So yes, it's a major problem, and we hope that we'll be able to tackle it. As has been pointed out, outdoor interventions, reducing screen time, reducing the distance of reading and tabs and phones are key interventions that are essential for preventing development and for progression of myopia. So thank you, Dr. Damaris. I think highlighting a very, very important, extremely essential, public health important issue for us. I'll request sir to... Yeah, Dr.
Exotropia and myopia linked. More myopia, more exotropia, and they are problems in arms, one helping the other one. So that's, I think, another thing which is increasing. Exotropies are also rising in incidence as myopia is rising.
Thank you so much. Now I will invite Dr. Nidhi. Dr. Nidhi to speak on retinopathy of prematurity and its relationship with anemia. Dr. Nidhi is consultant at NMCH, Sasaram, Bihar, and this is associated with the Narayana Medical College and Hospital.
Good afternoon.
And this is an extremely important topic because the number of children detected with retinopathy of prematurity, and there are lot of issues of concern in this. First is detection, then is the management.
Good afternoon, one and all. Retinopathy of prematurity is a vasoproliferative disorder of retina occurring in preterm babies having immature retina. And it is a potentially blinding condition. The image represents impact of ROP and distribution across the globe. The circle is all the babies affected by ROP. The darker color wedge represents babies severely affected by ROP. We can see that the impact is more in South Asian countries compared to high income countries, and also in low to medium income countries from Latin America, North Africa, Eastern Europe. So why should we screen for ROP? First of all, the premature babies are not born with the disease. They develop disease with due course of 4 to 5 weeks. So we get a window period in which if we detect and intervene timely, the potential blinding condition can be prevented. Who should we screen? So according to Rashtriya Bal Swasthya Kalyan,